So my name is Stephen Hughes. I'm a pharmacist at Chelsea Westminster Trust. I'm here presenting both the Trust and our Pharmacy Infection Network. And the plan is, over the next few moments, to go through some of the emerging concepts with the optimizing duration of therapy for antibacterials and how we can minimize resistance. Here are my disclosures. So for the next, as I said, 18-20 minutes, I won't keep these too long, we're going to look at understanding the selective pressure antibacterial usage does to our microbiome. So every time we give our patients or take ourselves an antibacterial, we are selecting out resistance, and that will have long-term impacts on future resistant infection rates. We'll critically evaluate some of the key papers coming through that is changing our practice, and look briefly on how we can implement these into practice, how we can introduce personalization of antibacterials. So let's start with something that's very familiar to this audience. What is resistance? We all know it's the selection of bacteria that are no longer susceptible to our life-saving treatments such as penicillin. It's a very much a natural phenomenon. These resistant mechanisms have been here a lot longer than we've had antibacterials, but what we're doing is we're selecting it out over time by using antibacterials non-discriminately in both human and animal health. And what it means for our patients ultimately is that patients who had previously had been treated with for relatively simple infections such as urinary tract infections or community-acquired pneumonia, they are no longer responding to the first-line, second-line treatments, often ending up coming into hospital for intravenous antibiotics. That is very common in our practice in Northwest London for UTIs. These are patients who are otherwise well but requiring intravenous antibiotics for simple treatment. Then we have the slightly more extreme cases, patients coming in with severe infection, those with sepsis, as we define it, who have a much more increased morbidity and mortality as a result of reduced treatment options. And usually the key determinant here is identifying these resistant organisms and treating them aggressively. Many of our first-line antibiotics that we use for chest infections, for urinary tract infections, will not cover these common resistant mechanisms. And this delays timely treatment and ultimately has poor impact or poor outcomes for our patients. And as we know, certainly within our local practice, we have patients who are colonized with and infected with resistant pathogens that we have no licensed treatments for. We have neonates born and within a few days colonized with these pathogens, very difficult to treat. And we do treat them. We used unlicensed therapies with lots of side effects and ultimately pretty poor outcomes. So once we have these infections, it's hard to treat. What we know is that the selective pressure, it's a very simple concept. We have a very rich and diverse microbiome, and we have lots of bacteria competing for space, for nutrients, etc. And then we introduce an antibacterial, either systemically, intravenously, or oral, and this will selectively reduce the susceptible pathogens. And over time, we're left with these resistant pathogens, and then the next time that patient gets infection, it's much more likely it's going to be a resistant pathogen. So this selective pressure is putting selective resistance on these pathogens and selecting out this resistance. So antibacterial exposure is a key determinant on resistance. Again, this room, we know lots about resistance, and we've had a few key resistant pathogens over time. So the original superbug from about 20 years ago, methicillin-resistant Staph aureus, and this is, again, colonizing the skin, causes invasive skin and soft tissue infections. Within the UK in particular, we've had huge reductions in the number of invasive MRSA infections, primarily due to the good work of our IPC team, recognizing MRSA colonization and offering the 5-day eradication and reducing the risk of onward infection. So MRSA is present. We've had new therapies to treat MRSA, and our risk of infection is much, much reduced due to the good work from the IPC team and the screening teams. The next gram-positive pathogen that we worry about for resistance is the vancomycin-resistant enterococci, or VRE, as we refer to it lovingly. And this tends to live in the GI tract, cause opportunist infections. It's probably less a concern for us because it's not very pathogenic. And by that I mean it does not cause invasive infection in patients with a good immune system. It tends to pick on our more vulnerable patients, particularly our renal patients and our hematology patients, and it can cause problems on our ITU population. But in general, it causes less of an issue for the general population. Where we see big concerns and where we are most concerned about resistance is with the bottom right corner and the resistant gram-negative infections. Here we see the most common infections, E. coli, Klebsiella, which cause invasive infections. Even in a healthy human, if you had an E. coli in your blood, you'll know about it. You'll feel very, very sick, and untreated, you have very high mortality, well above 40%, even in healthy patients. And are more vulnerable patients and much more susceptible to complications. They often encode quite complex resistant mechanisms. So the most common one we see in the UK is ESBL, which is extended spectrum beta-lactamase. And this ultimately means that our beta-lactams, so comoxiclav, cephalosporins, and even tazocin, are no longer reliable against these mechanisms. I'm coming from the northwest London. We have about 14 to 17% of our population coming through the door each day are colonized with ESBL if I go looking for it. So it is endemic within particularly our population. It will vary across the UK. If you're living in the extremes, Cornwall, up in the highlands of Scotland, you'll have lower rates. But if you're living in northwest London, you're probably the epicenter of ESBL. We've treated ESBL infections for many years with big, bold meropenem. And it's fantastic for treating invasive ESBL infections, but perhaps unsurprisingly, we are selecting out carbapenem resistance. So the carbapenem or CREs or CROs or CPEs, depending on your local definition, are resistant to most of the beta-lactams, if not all, including carbapenems. Very difficult to treat. We've had outbreaks in Manchester and the northwest of England, and also closer to home in northwest London. Very, very difficult to treat and quite a high mortality associated with them. So ultimately what we're here to do is minimize the complications of resistance. I think resistance is something we'll have to live with. It's unlikely to disappear in our lifetime, but we have to mitigate the risk of resistance, minimize the future selective pressure, and protect our patients and our future loved ones from these infections. Again, the most cost-effective intervention we can do is what we do every day with IPC. Preventing onward transmission is the single, simplest step we can do to reduce complications. There's also a role for the antimicrobial prescribing and stewardship team, so with our pharmacy and prescribing colleagues, to minimize unnecessary antibacterial usage. So we're aware that many patients are exposed to antibacterials for no good reason. Either they request it, or they got a viral infection, or it's just our overcautious nature of prescribing. But we're very confident giving patients antibacterials when we know that maybe 1 in 3 probably do not benefit from these treatments. So this unnecessary usage of antibacterials, but also the unnecessary durations. Again, we're very good at giving 7, 14-day courses when much shorter courses are required. This selective pressure is putting pressure on resistance, and it's putting that patient at an unfair disadvantage going forward because they're much more likely to get resistant to pathogens. So ultimately what we're aiming to do is have a sort of tailored therapy for our patients. So giving the right duration for the right patient at the right time. So moving away from one size fits all to personalizing our treatment. Again, some patients don't need any, some patients need very, very short courses, and some of our more vulnerable patients probably do need a bit longer as a response. And as you'll all probably agree, each patient is very different, and each patient's infection is very different. So those varying host factors, so we know extremes of age, are very young, preterm infants, and our aging population, much more susceptible to invasive infections, gram-negatives, E. coli's in the urine, etc. We know patients who are exposed to chemotherapy as part of their oncology or hematology are much more susceptible to invasive infections, and patients with immune deficiency, such as pregnancy, much more risk factors of getting listeria. We know patients with concurrent or comorbid diseases, liver disease, kidney disease, diabetes, much more likely to have an impaired immune system, much more likely to have invasive infections. We also know that the pathogen itself can have an impact. So we know bugs like Pseudomonas are very difficult, very sticky. So once they're in the system, particularly in the lung of someone with structural lung disease, so cystic fibrosis or bronchiectasis, it's very difficult to get rid of that Pseudomonas, and they get recurrent infection. Those infections develop biofilm and are very difficult to treat with antibacterials. And again, we also have the source control. Patients with complex, big collections need longer therapy. What we know from lots of studies. This is pediatric population, and this is looking at, on the x-axis is the number of days of antibacterials children are getting to over a 6-month period. On the left-hand side, you see no antibiotics, followed by less than a week, and then you see the next 2 columns over a week and over 2 weeks. So what this looks at is the development of strep pneumo resistance. So the more antibiotics we give these children over 6 months, the more resistance they get. I think this is a relatively simple concept and one that probably reflects our current practice. So by giving patients antibacterials, even if it's good intention, they will have future risks of resistance. You see it at an individual level, but you also see it at an environmental level. So this is countries. So on the bottom axis, this is the number of antibiotics they prescribe, and then on the y-axis, it's resistance to, again, strep pneumo. And you can see countries who prescribe more antibacterials have more resistance. So antibacterial exposure equals antibacterial resistance. And it's not just resistance we worry about. And again, we're all very familiar with our old foe, C. difficile infection. And again, there's certain antibacterials that we know cause selective selection of C. difficile. But probably the biggest unifying risk factor is duration of therapy. The longer my patient's on antibacterials, the more likely they will develop resistance. So patients on more than a week and patients on certainly more than 3 weeks will have almost 3- and 8-fold increased risk of C. difficile infection. Personally, I'm less concerned with the agent we give, I'm more concerned with the duration. So 21 days of antibacterial for an elderly patient puts much, much higher risk of developing C. difficile infection. So ultimately, the profession, the microbiology world, the antimicrobial world is moving to the view that shorter is better. If we can minimize durations of therapy in some of our patient groups, we can reduce their risk of resistance going forward. This was first introduced as a concept by Professor Llewellyn down in Brighton, probably 2 or 3 years, well, 3 or 4 years ago now, and he was suggesting that particularly for self-limiting infections, so upper respiratory tract infections, we would tell our patients to stop antibiotics when they feel better. This was met with a lot of opposition across the infection world because we've been telling patients to complete the course for so long. There is a likely middle ground somewhere, but I think at the moment we're not equipped with teaching the patients when to stop antibiotics and when to continue it. For example, if a patient had TB or infective endocarditis and they were to stop their antibacterials when they felt better, they would have a relapse infection pretty quickly and very severe complications of this. So at the moment, we're probably not able to pass this message on to the patients, but we're very able to pass this on to our prescribers, our nursing teams, our pharmacy teams, that if a patient in front of us is improving, they've got a self-limiting infection, that yes, we probably could stop antibacterials with minimal complications and with the knowledge that it'll reduce resistant pressure. The Americans have also jumped on board with this, and they are, in their very American, unique way, are pushing this mantra, shorter is better. Our colleagues, Professor Spellman on the left, has got his own website, and he's a big advocate of shorter durations for certain indications. And again, if you think about the logic to our prescribing, there is not much. Unless it's a number of fingers on one hand or days in the week, that is typically how we prescribe antibacterials. There's no reason why 7, 10, 14, 42 days are any better than 1 or 2 days either side. It's just a previous mantra. We sort of continue to do it, and we've never questioned it before. But now with the introduction of resistance, I think it's now time to question these mantras and adjust accordingly. So there has been a lot of work done on invasive gram-negative infections where we know the resistance is greatest. So for urinary tract infections with signs of systemic inflammation, so that is sepsis or pyelonephritis, so patients who are quite unwell, typically presenting to the hospital for treatment. We typically treat, and previously been treating for 10 and 14 days, and this work a few years back looked at could we just give a 5-day course of ciprofloxacin. Again, it's worth noting the population, the median age is 32, so this may not reflect the patients you see in your hospital. It's a relatively self-selecting group of young, healthy females with typically uncomplicated pyelonephritis. So it may not reflect our 85-year-old male who's quite unwell on the ward, but for our young, healthy females, it's quite useful. It randomized patients after 24 hours, comparing 5 days versus 10 days treatment, and outcomes-wise, there's no difference in mortality and clinical effectiveness. So from this, my takeaway is that shorter courses for uncomplicated, healthy patients is probably sufficient. The issues with all these studies is that they are very selective. There's lots of patients where they did not include and were not brave enough to study this. So patients with any definition of immunocompromised status, patients with prior UTIs, so if you had a UTI within the previous 6 months, which a lot of our patients will have, or if you've had recent ciprofloxacin in the last 6 months, these patients are all excluded. So this is a small proportion of the patients I treat on a daily basis, but it does not reflect all my patients. So again, this is useful information, but we must apply it to the most useful group rather than every patient. This slide, apologies, doesn't go in the best. This is looking at ciprofloxacin versus non-ciprofloxacin-based agents. And from their own analysis, they show that ciprofloxacin is very effective at short courses, but we are less confident with beta-lactams. And as you know, within the UK population, we have moved away from ciprofloxacin for UTIs because of its association with C. diff, and rightly so. And we're big advocates of comoxiclav and cefalexin. At the moment, this study did not demonstrate that short-course comoxiclav worked. So there's some questions still arising. We've also had studies looking at more invasive infections. So these are by definition patients with a bacteremia with a gram-negative infection. And I want to ask the question, is 7 days as good as 14 days? Can we give half the duration of therapy and get our patients home early? Again, it was a prospective study. They identified uncomplicated gram-negative bacteremias, if there is such a thing. Typically, they're a rather young population, predominantly urinary tract infection. The important thing is that they randomized at 48 hours, and the patient had to be quite well at 48 hours. So these patients are treated initially for a gram-negative infection. They respond very well to their initial treatment, and after 2 days of treatment, they're afebrile, they're hemodynamically stable, they have got no collections, no source control issues, and they're feeling much better. And when we randomize these population, we find that 7 days is as good as 14 days. Again, the issue will be there's a lot of exclusion criteria. So very elderly patients, patients with immunocompromised status, patients who've had recent antibiotic exposure, patients who've got any fever after 24 hours are excluded. So again, for a very self-selecting group, short course will work for these patients. Again, this study was done in Israel, and they are very fluoroquinolone biased. So they use ciprofloxacin or levofloxacin predominantly, which does not reflect our UK practice. Very few patients received beta-lactams, and almost none received comoxiclav. It was typically a third-generation cephalosporin, which is not practiced in the UK. So in practice, how can we infer all these new evidence base coming through? So again, our job is to interrogate the evidence base and translate that into our practice for our patient benefits. So we've had new studies coming through that showing for some patients, shorter courses is sufficient. I buy into this. I think the data is good. It's our job is to interpret this and to apply it into practice. So for patients at day 0, when we're starting smart empiric therapy, we treat aggressively for uncomplicated UTI or pyelonephritis. And then at 48 to 72 hours, I think that's when we can make an informed decision. If my patient is eating and drinking, is well, no fevers for the last 24 hours, no collection on urinary tract ultrasound, and his blood pressure is well controlled, I'd be very happy to step down to a shorter course, particularly with ciprofloxacin. There's less information available on comoxiclav, but for very well patients, I probably would chance it. For everyone else, I'd probably sit in the middle and maybe go for 10 days. And then for patients with more complex infections or ongoing fevers, I'm probably going to leave them with the standard 14 days because I'm still got some anxieties that they're increased risk of infection. What I don't know the answers to is patients who've got immunocompromised status or patients with prosthesis, so if you have a unresolved stent, etc., in the urinary tract, or if it's a non-urinary tract infection, there's less information available. At the moment, this is where we're debating 10 versus 14 days. So all of this information is useful, but it's our job to implement this and make it useful for our junior prescribers. They're not going to have the time to interrogate these studies, to go through the pros and cons. So we have to convert this quite complex message into something that's achievable and workable for our junior doctors. This is an extract from our local UTI or pyelonephritis guidelines within Chelsea and Westminster. Due to our very high rates of ESBL, we're using amikacin as our treatment of choice. We have lots of resistance to gentamicin, unfortunately, in northwest London. And then we use the 48-hour review advocated by Public Health England to review the patient and come up with a decision at that stage. I do not believe at day 0 we know enough about the patient and the treatment to dictate if it'll be a 5, 7, 10 or 14-day course. But after 2 or 3 days, I'll have a good feel for the patient as well as prescribers, and then we can make an informed decision on the optimum duration. So for many patients who are responding well to treatment after 2 days, afebrile, eating and drinking, we can step down to an oral therapy with comoxiclav or ciprofloxacin. Again, the overwhelming evidence shows that Cipro for 7 days is excellent. Less information on comoxiclav. We're a bit more nervous at Chelsea, so we advocate for 10 days. And on the right-hand side, patients who are not responding, we want to go up and escalate and give them more aggressive treatment, either temacillin, if they've got ESBLs, or Cipro, ceftriaxone. And those patients are likely to benefit from the 14 days because they're more complex infections. So with that, I'll stop and summarize. So I think as we move into more complex times for infection, particularly with resistance, we have to move away from the one-size-fits-all and move to tailoring therapy. We know patients do not respond equivalently to different treatments. They have different infections, different resistant mechanisms, and different comorbidities themselves. So our job is to introduce tailoring therapies into practice to ensure that each patient gets the optimum duration, a bit like the Goldilocks effect. So our job is to operationalize this into hundreds of patients each day, which is a challenge in itself. We know that for resistance reasons, if we can shorten the duration of therapy, we can minimize the risk of resistance. So ultimately, the theory behind it is strong. The rationale for doing it is strong. It's the operationalizing, as always, is the challenge. We know that, again, the dose optimization, I haven't discussed it much here, but we know that aggressively dosing these patients to overcome early level or low level resistance is key, and this gives us the firm base to de-escalate. So again, locally, we are very aggressive with our treatment, particularly in the first 48 hours. We aggressively treat these infections. We want to get on top of the infection, and then once the patient's feeling better, we can reduce it down to tablets and send the patient home. This gets the patient home early. They get back, they sleep in their own bed, they eat their own food, and they're not picking up all the nasty surprises we have in hospital for them. And then finally, I suppose it's just sort of consolidating the importance of the 48 to 72-hour review. This has been a very clear strategy from Public Health England for antimicrobial stewardship. The importance of not moving away from a single point of transaction. Day 0, I prescribe an antibiotic and I walk away and I've done my job. To it's almost a follow-up review. Prescribe an antibiotic at day 0, that's the easy bit. And then I follow my patient up after 48 hours and I review them. I look at their microbiology, I look at their response, and I do something at this point, either escalate if they're not doing well, or de-escalate to get them home if they're doing well. So again, this is just reaffirming the importance of 48 hours review.